Ladies and gentlemen, first, let me thank Professor Judy Wasserheid for inviting me to participate in this important event. Let me also congratulate the University of Washington for the great contribution and impressive achievements in global health over the past 10 years. Thank you also for focusing in this symposium on one of the greatest challenges in global health, non-communicable diseases, or NCDs. I think this event comes at a very critical time in the global campaign against NCDs. A major breakthrough was made in 2011 at the UN General Assembly in New York by the heads of states and government endorsing the political declaration on NCDs, which resulted in a tremendous increase in awareness among policymakers worldwide, and it also provided the right vision and clear roadmap to address this global challenge. However, the progress in translating this vision and the roadmap into concrete action in countries has been inadequate and uneven. And this was the conclusion of the second UN high-level meeting on NCDs in 2014, which called on countries to scale up and report back in a third UN General Assembly meeting in 2018. So countries and other stakeholders are now given another critical opportunity to demonstrate positive progress and make a difference in less than 2 years from now. So I thought it would be useful and appropriate at the beginning of the panel discussion to provide an overview where we are today and propose areas where more effective action is needed. But let me start with a brief outline of the magnitude. According to WHO's 2015 estimates, NCDs cause around 70% of all deaths, more than 39 million deaths out of a total of 56.4 million. And here 3 points need to be highlighted. First, contrary to previously held belief, most NCD deaths, almost 3/4, occur in low and middle-income countries. And the second point is that 4 major NCDs, which are cardiovascular diseases, diabetes, cancers, and chronic lung diseases, are estimated to cause more than 80% of NCD deaths. So if you want to make a difference, the focus should be on addressing these 4 diseases. And thirdly, a major proportion of NCD deaths occur prematurely. More than 9 million NCD deaths were estimated to occur before 60 years, and almost 17 million deaths before the age of 70. The 4 key modifiable risk factors for NCDs are tobacco use, unhealthy diet, physical inactivity, and the harmful use of alcohol. They are shared by the 4 groups of NCDs that I mentioned before. So the NCD Global Strategy, endorsed in the year 2000 by the World Health Assembly and subsequently adopted by the United Nations and the SDG agenda, focuses primarily on the 4 groups of diseases and the 4 major risk factors. My colleagues will undoubtedly elaborate on this in their interventions, but the point I want to make is that the magnitude of risk factors and their increasing trend are again generally worse in low and middle-income countries. Let me now move to the global response to NCDs. In 1998, Dr. Brundtland, then Director General of WHO, elevated the priority given to NCDs by establishing a special cluster for NCDs, and she initiated work to develop a global strategy for non-communicable diseases. And as Director of NCD Prevention, I was then privileged to coordinate this work. The global strategy was endorsed by the World Health Assembly in the year 2000. The strategy is based on the overwhelming evidence that premature mortality from NCDs is largely preventable. It focused on the 4 groups of NCDs that are responsible for more than 80% of NCD deaths and that share the same risk factors and also the same preventive strategies. The broad strategic directions were simple. Firstly, countries need to track or monitor NCDs and their risk factors, which is the surveillance component. And secondly, they should be able to prevent NCDs by preventing or reducing risk factors. And thirdly, countries need to strengthen health systems to improve healthcare for people with NCDs. Then, based on the 2000 strategy, a series of milestones provided a comprehensive roadmap for NCD prevention and control. In 2003, the Framework Convention on Tobacco Control was endorsed by the Assembly, followed by the Global Strategy on Diet and Physical Activity in 2004, the first Global Action Plan on NCDs that translated the strategy into action in 2008, and the Global Alcohol Strategy in 2010. And these developments and the evidence generated on socio-economic impact of NCDs led to the inclusion of NCDs in the agenda of the ministerial meeting of the Economic and Social Council of the United Nations, which is the ECOSOC, in the year 2009. I mention this point because I want to highlight the fact that NCDs is not just a health issue. It's the outcome of this meeting that was actually key in moving the NCD movement from the World Health Assembly to the UN General Assembly, and in the adoption in 2010 by the Assembly of a resolution requesting a high-level meeting of heads of state and government on non-communicable diseases the following year. The high-level meeting in New York in September 2011 endorsed a detailed political declaration, which provides a list of commitments that each country agreed to make. In practical terms, the commitments made in 2011 can be summarized by a set of measures that countries should implement in 4 areas of work: governance, surveillance, prevention, and healthcare. And in the area of governance, the key commitments were to set national targets for 2025, taking into account the 9 global targets recommended by the World Health Assembly, and to establish a national multi-sectoral NCDs policies and plans. Now, in this slide, you see the 9 global targets. The overarching one, of course, is the 25% relative reduction in premature mortality, 30 to 70 years, by 2025. And a similar target was adopted by the Sustainable Development Goals in 2015, but with a 30% reduction by 2030. In the surveillance area, the key commitment was to strengthen NCD surveillance and integrate it into the national health information systems. And here it's important to remember that NCD surveillance is not just risk factors monitoring. Equally important is to monitor morbidity and cause-specific mortality, and to assess the performance of the health system in responding to the NCD healthcare needs of the population. In the area of prevention or risk factors, the commitments are to implement the cost-effective interventions or the best buys recommended by WHO. The best buys are based on the fact that all countries have to make difficult choices on how best to allocate resources for health, and they need to focus also on the interventions that meet 4 criteria. First, they should be cost-effective. Second, they should be of high impact. Third, they can be implemented within available resources. And fourthly, they can be feasibly scaled up, particularly in resource-constrained settings. And here you see the best buys recommended by WHO. Last week, an updated version was endorsed by the WHO Executive Board. And here in the University of Washington, extensive work is being conducted as part of the Disease Control Priorities 3 project to develop a high-priority package of cost-effective interventions for NCDs and other priority health conditions as one of the 3 key dimensions of universal health coverage. In the area of healthcare, the commitment is to strengthen health systems. One prerequisite to improving access to healthcare is to integrate the early detection and management of common NCDs, including hypertension, diabetes, and commonly encountered curable cancers, into primary healthcare. Now, funding is obviously key. So how much does it cost to implement the best buys? In 2011, WHO conducted an economic study to define the approximate cost of scaling up these best buys. And this slide summarizes the result of the study. For all low-middle-income countries, you need $11.4 billion per year on average. This is a very small fraction of the cost of inaction, which amounts to trillions, according to another study conducted by Harvard and the World Economic Forum at the same time. On a per capita basis, the annual investment ranges between less than $1 in low-income countries to $3 in upper middle-income countries. So the cost of targeted investment is low, and the budgetary impact of the scale-up is low to modest. But the key message is that all countries can do something. Now, this is a framework for action that we have recommended to countries. It summarizes what it takes to address the NCD epidemic according to the United Nations General Assembly recommendations. It has 17 action points and 10 indicators that are used by countries to monitor the progress they are making. And the same 10 indicators will also be used to prepare the report of the United Nations Secretary General to the high-level meeting on NCDs in 2018. Finally, I want to spend the last few minutes on where countries are and what deserves more attention. And as I said, the assessment of the follow-up 2014 General Assembly meeting on NCDs indicated lack of adequate progress, despite the clear vision and the sound roadmap. And this is also supported by available information on the rate of implementation of the best buys and other globally recommended measures since 2011. It is clear from the process indicators set to measure the implementation of the best buys that most countries are not on track. And here are some examples. Only a small proportion of countries have made the highest achievement in at least 4 of the 6 proven tobacco control measures. And an equally small proportion of countries have effective programs to reduce the intake of salt and trans fat. Less than 1/4 of countries have an NCD surveillance system that enables them to report on the global NCD targets, and access to the essential healthcare interventions to early detect and manage common NCDs are generally lacking, particularly in low-income countries. So why is this slow progress? I think there are several reasons for this. One is that the declared commitment made by the countries at the UN in 2011 has not been translated into effective action. And we need to think how this gap can be addressed. Second is the need for technical guidance on implementing the recommended best buy interventions. We often think that when recommendations are made to countries, they should be automatically implemented. But this is not always the case. Very often, policymakers will basically agree with recommendations like increasing tobacco taxation or reducing salt, but they need to know the know-how, and they need the technical support to implement them based on international experience, best practice, and implementation research. And this highlights the critical importance of implementation research, translating knowledge into action through innovative approaches. In 2010, WHO developed a prioritized agenda for NCD research, but this needs to be reviewed now, and it needs to be updated, focusing on recent developments and also on the needs of policymakers. This was also one of the key recommendations of 5 policy forums organized by the DCP3 project over the last 2 years, and I'm pleased that this will be part of the objectives of the DCP3 country translation phase. I also hope that the University of Washington and other international institutions represented here today will work together to enhance international collaboration, to promote and support the multi-dimensional and multi-sectoral research that is needed to generate or strengthen the evidence base for NCDs. And the third reason for the slow progress is the weak health system, impeding the integration of healthcare for common NCDs, particularly at the primary healthcare level. There are major gaps in all health systems, building blocks that will need to be addressed by low and middle income countries as part of the universal health coverage SDG target, particularly in relation to financial risk protection and the adoption of an essential package of health interventions, which include, obviously, the NCD best buys. The fourth reason are the competing interests and the obstructing forces which continue to impede progress and remain largely unopposed in many countries. The tobacco industry is a clear example. but there are also seriously unopposed marketing practices in other areas like food that should receive high priority. Fifth is the lack of adequate funding, particularly in most low and lower middle-income countries. NCD funding, unfortunately, remains of low priority for donors and in the development assistance agenda. And there are currently some proposed approaches to address this, and I know that my colleagues in the panel will be commenting on this issue. And finally, sixth, is the need for a more effective intersectoral action. Most, if not all, of the population-based Best Buys cannot be implemented without active engagement of several important non-health sectors. So how to strengthen intersectoral action and build capacity in health leaders in this area will need to be at the center of attention. There are already concrete guidelines on steps to engage other sectors based on successful international experience, but here again, more evidence needs to be generated, focusing on the mutual benefits of multi-sectoral work. Ladies and gentlemen, my last point is that for countries to move forward and to scale up action against non-communicable diseases, these impediments need to be addressed, and I'm confident that this will be part of the focus of discussion during this session. Thank you for your attention.